Liver cancer, also known as hepatocellular carcinoma, HCC, is a type of cancer that begins in the cells of the liver. It is a relatively uncommon form of cancer in comparison to other types, but it can be a serious and life-threatening condition. Risk factors for liver cancer include chronic infection with hepatitis B or C, cirrhosis of the liver, often caused by alcohol abuse or non-alcoholic fatty liver disease, certain genetic conditions, and exposure to aflatoxins, toxins produced by a fungus that can contaminate certain foods. Symptoms of liver cancer may include unexplained weight loss, loss of appetite, abdominal pain or discomfort, especially in the upper right side, jaundice, yellowing of the skin and eyes, fatigue, nausea and vomiting. Diagnosis typically involves imaging studies such as CT scans or MRIs, as well as blood tests to assess liver function. A definitive diagnosis may require a liver biopsy. Treatment options for liver cancer depend on the stage of the cancer and the overall health of the individual. They may include surgery, liver transplantation, chemotherapy, targeted therapy, and radiation therapy. In some cases, a combination of these treatments may be recommended. It's important for individuals with liver cancer to work closely with a healthcare team to determine the most appropriate treatment plan for their specific situation. Additionally, support from friends, family, and support groups can be beneficial for emotional well-being during the challenging journey of dealing with cancer. If you or someone you know is facing a possible diagnosis of liver cancer, please consult with a healthcare professional for personalized and accurate information based on the specific circumstances. Classification. Liver cancer can come from the liver parenchyma as well as other structures within the liver such as the bile duct, blood vessels and immune cells. There are many subtypes of liver cancer, the most common of which are described below. Hepatocellular carcinoma. Liver tumor types by relative incidence in adults in the United States. Liver cancers in dark red color. The most frequent liver cancer, accounting for approximately 75% of all primary liver cancers, is hepatocellular carcinoma, HCC. HCC is a cancer formed by liver cells, known as hepatocytes, that become malignant. In terms of cancer deaths, worldwide HCC is considered the third most common cause of cancer mortalities. Causes. Viral infection. This electron micrograph shows hepatitis B virus, Dane particles, or virions. Viral infection with hepatitis C virus, HCV, or hepatitis B virus, HBV, is the chief cause of liver cancer in the world today, accounting for 80% of HCC. Men with chronic HCV or HBV are more likely to develop HCC than women with chronic HCV or HBV. However, the reasons for this gender difference is unknown. HBV infection is also linked to cholangiocarcinoma. The role of viruses other than HCV or HBV in liver cancer is much less clear, even though there is some evidence that co-infection of HBV and hepatitis D virus may increase the risk for HCC. Cirrhosis. High magnification micrograph of a liver with cirrhosis. Trichrome stain. The most common cause of cirrhosis in the Western world is alcohol use disorder, the cause of cirrhosis in this case. In addition to virus-related cirrhosis described above, other causes of cirrhosis can lead to HCC. Alcohol intake correlates with risk of HCC, and the risk is far greater in individuals with an alcohol-induced cirrhotic liver. There are a few disorders that are known to cause cirrhosis and lead to cancer, including hereditary hemochromatosis and primary biliary cirrhosis. Aflatoxin. Aflatoxin exposure can lead to the development of HCC. The aflatoxins are a group of chemicals produced by the fungi Aspergillus flavus. The name comes from A. flavus toxin, and A. parasiticus. Food contamination by the fungi leads to ingestion of the chemicals, which are very toxic to the liver. Common foodstuffs contaminated with the toxins are cereals, peanuts, and other vegetables. The amount, dose, and how long, duration, that a person is in contact with aflatoxin is associated with HCC. Non-alcoholic steatohepatitis, NASH, and non-alcoholic fatty liver, NAFL. NASH and NAFL is beginning to be called a risk factor for liver cancer, particularly HCC. In recent years, there has been a noted increase in liver transplantations for HCC that was attributable to NASH. More research is needed in this area and NASH, NAFL. Children. Childhood liver cancer is uncommon. The liver cancer subtypes most commonly seen in children are hepatoblastoma, hepatocellular carcinoma, embryonal sarcoma of liver, infantile choriocarcinoma of liver, and biliary rhabdomyosarcoma. Increased risk for liver cancer in children can be caused by Beckwith-Wiedemann syndrome, associated with hepatoblastoma, familial adenomatous polyposis, associated with hepatoblastoma, low birth weight, associated with hepatoblastoma, progressive familial intrahepatic cholestasis, associated with HCC, and trisomy 18, associated with hepatoblastoma. Diagnosis. Many imaging modalities are used to aid in the diagnosis of liver cancer. For HCC, these include medical ultrasound, computed tomography, CT, and magnetic resonance imaging, MRI. When imaging the liver with ultrasound, large lesions are likely to be HCC. E.g., a mass greater than 2 cm has more than 95% chance of being HCC. Given the blood flow to the liver, HCC would be most visible when the contrast flows through the arteries of the liver, also called the arterial phase, rather than when the contrast flows through the veins, also called the venous phase. Sometimes doctors will get a liver biopsy if they are worried about HCC and the imaging studies, CT or MRI, do not have clear results. The majority of cholangiocarcinomas occur in the hilar region of the liver, and often present as bile duct obstruction. If the cause of obstruction is suspected to be malignant, endoscopic retrograde cholangiopancreatography, ERCP, ultrasound, CT, MRI and magnetic resonance cholangiopancreatography, MRCP, are used. Prevention. Prevention of cancers can be separated into primary, secondary, and tertiary prevention. Primary prevention preemptively reduces exposure to a risk factor for liver cancer. One of the most successful primary liver cancer preventions is vaccination against hepatitis B. Vaccination against the hepatitis C virus is currently unavailable. Other forms of primary prevention are aimed at limiting transmission of these viruses by promoting safe injection practices, screening blood donation products, and screening high-risk asymptomatic individuals. Aflatoxin exposure can be avoided by post-harvest intervention to discourage mold, which has been effective in West Africa. Reducing alcohol use disorder, obesity, and diabetes mellitus would also reduce rates of liver cancer. Diet control in hemochromatosis could decrease the risk of iron overload, decreasing the risk of cancer. Secondary prevention includes both cure of the agent involved in the formation of cancer, carcinogenesis, and the prevention of carcinogenesis if this is not possible. Cure of virus-infected individuals is not possible, but treatment with antiviral drugs can decrease the risk of liver cancer. Chlorophyllin may have potential in reducing the effects of aflatoxin. Tertiary prevention includes treatments to prevent the recurrence of liver cancer. These include the use of surgical interventions, chemotherapy drugs, and antiviral drugs. Treatment. Like many cancers, treatment depends on the specific type of liver cancer as well as stage of the cancer. The main way cancer is staged is based on the TMN staging systems. There are also liver cancer-specific staging systems, each of which has treatment options that may result in a non-recurrence of cancer, or cure. 57, 58, 59. See radiofrequency ablation. For example, for HCC it is common to use the Barcelona Clinic liver cancer staging system.